Patient's moving right away at 1 week. The key is supine elevation exercises. We remove the fixator at 6 weeks. We have the patients do their own exercise and work with the therapist as needed. I emphasize supine elevation as the key. Here's an example of a 3-part fracture in an elderly gentleman who was skiing. There's obvious displacement here of the greater tuberosity and the head-neck angle. He underwent external fixation as one of our first cases, and you can see him working hard in his supine elevation, and you can see him being active with his fixator on in the gym. Post-operatively, he did very well with good restoration of motion, strength, and he's back to his activity as usual. Here's a case with slightly more complexity that taught me a lot about proximal humerus fractures using the fixator. The greater tuberosity is multi-fragmented, and despite multiple attempts at reduction, the tuberosity continued to fragment. However, with obtaining good sagittal plane reduction, we were able to get what I think is a suitable reduction despite the X-ray evidence of a slightly high greater tuberosity. Importantly, the fixator captured the myotendinous unit of the greater tuberosity, infraspinatus and supraspinatus, and allowed excellent forearm elevation. And importantly, again, sagittal plane reduction was restored, allowing for good motion. Here's active motion at 10 weeks before therapy was even initiated. And this has been typical of our cases, and here's 1 year. Getting back to our video, here again is the case with a simple 2-part and a small fragment of the greater tuberosity. Here you can see excellent restoration of sagittal plane and AP view. This patient had mild Parkinson's, and you can see even at 10 weeks post-op, excellent early range of motion before therapy is even initiated. Now at 10 weeks, you can see active motion proceeding very well, and again, this has been typical from what we've found. Here's an example of several cases that we've had, again, in various stages of post-op course, somewhere between 8 weeks and 6 months. In summary, we've experienced mixed outcomes after proximal humerus fractures due to age, rotator cuff disease that coexists, implant failure or complications, and importantly, malunion and non-union. In my opinion, there's been a fair bit of benign neglect because the current surgery options just seem too much for the patient. In conclusion, external fixation, I believe, offers a low morbidity option for proximal humerus fixation. It allows for short operative time, and for us, we've taken anywhere from 22 minutes to 55 minutes for skin to skin placing this fixator on. It offers stable fixation, which restores sagittal plane alignment, which I believe is the priority in terms of proximal humeral fracture fixation. There's very little soft tissue disruption, which is important to maintain tuberosity vascularity.